So, briefly, the suggestions and opinions presented here do not represent those of Snohomish County, my medical director, or Fire District 17, Granite Falls. They are also not substitution for common sense or orders or advice from an actual doctor, and please do not mistake them as such. Now, let's get into it. So, where we're at now, the epinephrine did not work. You gave the appropriate dose of epinephrine via the appropriate route to your anaphylactic patient. And whatever is wrong with them, whatever you were hoping to treat, be it shortness of breath, airway swelling, hypotension, or could be a mix of all three, it's still there. The epinephrine did not do anything. What do you do now? First, you make sure the ALS is on the way. Now, ideally, an advanced life support unit was dispatched with you to this fiasco, but dispatchers can only work with what they're told, and very occasionally that leads to very gross under triage. So just make sure that an ALS unit is coming to help you. If you are the ALS unit, fantastic, you're already there. Now, why does this matter? Medic units have a lot of tools to treat anaphylaxis. We can give more IM epi just like you, but we can also give epi drips, which I've had tremendous success with. You can give Benadryl and Solumedrol to try to address the root cause of the anaphylaxis, though those do not tend to work for several hours. A fluid bolus for hypotension. I can try glucagon in a patient that's on beta blockers. We'll talk more about that later. And if that all failed, if the patient's airway swelled shut anyway, I can intubate to try to protect them as a last-ditch effort, and if that fails, I can give them a Craig. So make sure all of this help is coming for you and for your patient, or that you're on your way to a rendezvous. Either way. Now, first things first, you need to wait for 3 to 5 minutes. IM epinephrine does not work immediately, and 3 to 5 minutes can feel like a lifetime when you are with a crashing anaphylactic. It could even be longer if, to name a crazy example, your patient is in anaphylactic shock, they're not perfusing very well. So a drug in the muscle might just chill there for a little bit. But still, what are you gonna think about and do while you're waiting? First, let's talk about injection issues. Issues with the actual injection that may have led to a failure there. First question, did you actually inject the patient with the actual drug from the vial? Now, if you have an epi auto-injector, then yeah, I'm going to say you probably did actually inject them with epinephrine, but as far as I know, most districts don't use those anymore because they're so expensive. So we do check and inject. Did you actually draw epinephrine out of this vial and inject it into the patient? This may sound like a ridiculous question, but this is a shockingly common error, especially with newer providers that are nervous or providers that are not accustomed to drawing up drugs and what a syringe full of liquid looks like versus what a syringe of air looks like. So you're going to check this vial and you're going to make sure it's missing 0.3 milligrams of epinephrine. How are you going to do that? You're going to draw up all the liquid in the vial. There should be 0.7 mils of liquid left. That is because we started with 1 mil of liquid. At least, hopefully, you took out 0.3 mils of liquid, ergo, there should be 0.7 left. Now, if there is 1 milliliter of liquid left, you injected the patient with air, it happens. What you're going to do is immediately redo the injection. You're going to get somebody to help you to make sure you end up with liquid in the syringe. You're going to make sure that you have the vial upside down when you are drawing out of it. Okay, now let's say the vial has 0.7 as expected. So nope, you did in fact inject epinephrine into this patient. All right, next question. Does the patient have a lot of fat? Now, in my district, the needles we use tend to be, gosh, an inch, inch and a quarter, nothing too dramatic. And our location for injection is the lateral thigh. Now, plenty of patients have more than an inch of fat on their lateral thigh. So what that can lead to is that you might have injected into the fat instead of the muscle. This is a problem. This tissue does not have nearly as good of blood flow, and it could cause the drug to work more slowly or not at all. So if you think this is what happened, you're going to give another injection. This time, you're going to give it in the deltoid. So that's outer shoulder right here. No big deal. So very, very few people have thick layers of fat over their deltoid, so this should be good to go. If you have a longer needle, I don't. Sure, consider that, whatever. But the deltoid, the 1 1/4 inch needle, should be more than sufficient for an injection into that area. Now let's talk about issues with the patient. Let's say you have definitely correctly injected actual epinephrine into the patient. Now, what are some problems with the patient that could be leading to this lack of response? Okay. Is your patient on beta blockers? Now, beta blockers, very commonly prescribed. Metoprolol, propranolol, atenolol, carvedilol, these are all ones that we hear all the time. They tend to end in lol. That tends to be beta blockers because beta blockers cause funny vitals. Is it stupid? Yes. But will you remember it forever? Also, yes. Beta blockers end in lol because they make vitals funny. Now, the beta pathway. Let's talk about it. The beta pathway is your fight or flight. So you sweat, your heart rate increases, your bronchial tubes dilate, your veins constrict, that's part of your muscles tensing, and you are ready to fight for your life or run for it. That is your beta pathway. Now, briefly, what does a beta blocker do you think? Now, it blocks that fight or flight pathway. The receptors on it, beta blockers, they're an antagonist, so they are physically blocking it from things like your nice agonist. To name a crazy example, epinephrine. So your patient may have all of their beta receptors already spoken for from a drug they took this morning, and that would cause the epinephrine to have nothing to bind to, nothing to possibly affect. So these drugs are commonly prescribed for patients with heart problems, where if they have that fight or flight response, that could be a big deal for them. Their heart can't handle going 140 beats per minute, so they're on beta blockers, so they'll be at 60 pretty much no matter what happens. I have also heard of these being prescribed to people with really serious anxiety disorders because beta blockers make it almost impossible to have a panic attack. So be aware that that's a possibility. Try to get a medical history. Now, if that happens, make sure you tell your incoming medic unit about the beta blockers immediately in your report. They need to know right away because I'm not going to be able to make epinephrine magically work here either. But we have some other options. We can give glucagon, 3 megs. So that's 3 of these little vials of it. We only have 2 on our rig, so make sure you consider having a second rig coming to you. And then ipratropium. Until it works, keep giving them ipratropium. You're not making it worse. So keep in mind, we may not have enough glucagon, and you need to give it IV. However, there was a case study where a 54-year-old female with epinephrine-refractory anaphylaxis was successfully saved with 3 milligrams of glucagon. It does happen. That woman was on a very high dose of metoprolol, so that epinephrine was never going to work. Now, a few other questions to ask. Is the patient still being exposed to the allergen? Now, a lot of times the patient ingested the allergen, and there is a big fat nothing we can do about that. It's in their stomach. In their stomach is where it is staying. However, some other possibilities. Maybe the bee stinger is still in, and use your ID card or something to remove that, because bee stingers can inject venom for a long time. Maybe it helps. Maybe your patient has been exposed to latex, and you need to remove that from their skin. Maybe they're having a reaction to a drug patch, and that needs to come off. So check it out. Make sure that they're not still sitting there being exposed to the allergen in a way that you can change while you're chilling. Okay, now in my district, you give a second injection. You don't need to ask medical control for the second one. After 3 to 5 minutes have gone by and there's no relief, give them another injection. It might help. At that point, God willing, ALS is there to bail you out. Another thing at this point I need you to consider is this definitely anaphylaxis? Are you positive? There are other things that can cause hypotension and wheezy lung sounds. I once mistook a patient with cardiac wheezing in the presence of congestive heart failure as an anaphylactic. Just make sure you're not making a mistake like that. Pause for a second, check your heart rate before you check the patient's heart rate, and think about it. Now, and then for our ALS providers, our old friend, the EpiDrip. I have never had this not work, but just as a quick review, to make 4 mics per mil, you put 1 meg of epinephrine in a 250 ml bag, and you use 2 megs in a 500 ml bag. If you work in my district, we don't have a 250 ml bag, so you just double it. Don't make your math hard, just double it. Use a 60 drip set, and you titrate from 2 to 10 mics per minute. So that's from 1 drop every 2 seconds to 5 drops every 2 seconds. If you have an IV pump, congratulations, you should definitely use that. That will be way more accurate. So the reason this works so well is because this is going into an IV. So 1 meg of epinephrine is a lot when it's going straight into a vein. So this is very effective. It's far less reliant on the patient's perfusion status, and it will basically start working immediately. The entire blood volume circulates through the body in 90 seconds, so that is very helpful for your refractory anaphylactic. And finally, and I always want you to remember this, this is always an option, always and forever. If all else fails, if you genuinely don't know what else to do, if you are drowning, ask for help. There is no shame in that. Ask for another unit to come in, call medical control, call your captain, call another medic. EMS is a team sport. We never for a single second have to do any of this alone.